name is Abby, and I am presenting on internal impingement. Just start out a little bit of history information. In 1959, Bennett described posterior shoulder pain in professional baseball players, and this is what led to the examination of internal impingement. So basically, internal impingement is the excessive contact of the greater tuberosity of the humeral head with the posterior-superior aspect of the glenoid during abduction and external rotation of the shoulder. And then another part of this is the impingement between the rotator cuff and the joint capsule. So one thing to point out is this internal impingement is different from the classic impingement described by Neer. The mechanism of injury, it's insidious onset, which means it's usually chronic, and it comes from repetitive overhead motion. So you see this a lot with baseball players, probably some softball players, could see it with volleyball, some tennis, and swimming. So, for evaluation, things that you might see, you'll probably see some forward shoulder posture, probably some forward head posture. The pain will be just inferior to the acromion on the posterior side of the shoulder. They will probably present with excessive internal rotation. Sorry, that doesn't make sense. Excessive internal rotation, limited, I think that was supposed to be external rotation, and horizontal abduction. Some of the special tests that you can use to evaluate this that we just learned today is the Neer test, so internal rotation and passive flexion, the Hawkins test where we learned right there today. You're going to have increased pain with the apprehension test, and like Dave said, you want to make sure that you're asking where the pain is, because that's going to help you differentiate. And you'll have decreased pain with the relocation test. So minor impingement may be asymptomatic when you're in abduction and external rotation, so that's something to keep in mind, that just because they aren't painful right here doesn't mean that they don't have it. It's just probably in the early stages. The signs and symptoms, pinching sensation, popping and clicking, and pain deep in the posterior shoulder. And that's the most important one, is where is the pain. So the figure that's on your sheet is an arthroscopic view of the shoulder. I just want to share this with you guys because you can see the difference in the congruity of the rotator cuff and the superior labrum when it's in neutral, and then once they're into maximal abduction and external rotation. So that's just showing you inside the shoulder what is actually happening. So as far as treatment, your non-operative treatment, rest is the big thing. You want to focus on pain relief using cryotherapy, NSAIDs, lymph drainage, and neuromuscular facilitation. And then the other big thing you want to use is stretching, like the posterior capsular stretch that we talked about in the article. I think it said it helps in like 90% of the patients. For the operative treatments, there's arthroscopic debridement, subacromial decompression, anterior capsule labral reconstruction, and of course, while they're in there doing any of that, they would repair any of the other affected structures. Any questions?